Well, welcome everybody to this talk about important talk about police reform and using a cognitive behavioral therapy training. So we have two presenters. Ashley Wilson has experience in community mental health on ACT and supported employment. She started as a certified peer specialist and worked her way to a therapist who focuses on family education. And then Stephen Betucker has been working with people labeled seriously and persistently mentally ill since 2001, working in Illinois, Ohio, and North Carolina. And he has extensive experience with ACT implementation, developing high fidelity ACT teams, and rebuilding struggling teams. So without further ado, take it away.
Thank you so much. Looks like everyone can hear us. All right, let's go to our objectives, which are to apply the CBT, the cognitive behavior therapy for psychosis approach, to engage in individuals with psychotic disorders in response to the 911, the emergency calls here in the United States, to recognize how CBTP can reduce mental health stigma within the United States police departments, and utilize CBTP to improve psychoeducation for those who experience psychosis.
Yeah. All right. So back last year in 2020, not only were we dealing with a global pandemic, but in the United States, we were also dealing with a lot of different things, but something that got brought to light was the death of George Floyd, and that happened on May 25th, 2020. And the death of George Floyd increased the intention on the response of police in the United States, and also resulted in conversations about how police address mental health and substance use disorders. It's really important to understand this because there have been many individuals who have lost their lives, but George Floyd is kind of like the domino effect that has really tried to create a domino effect of change and police reform in the United States. So why are the police even involved? So police in the United States often are they're called to many different situations that are happening, and they get find themselves doing community mental health work regardless of that's their position or not, right? So police are often both the initial link and the go-between individuals and mental health services. And so that's really important to really think about, wow, like they may be the initial link. They're that first person that may interact with them to help them get mental health services. So in order to truly understand why the police have gotten involved is to let's go back in time. Let's take a look back and understand what was happening. And so in the United States, we have had multiple concerns around improperly housing people with mental illness, a lot of segregation stuff happening. And what happened was that the United States wanted to deinstitutionalize a lot of individuals that were in the state psychiatric hospitals, adult care homes, group homes, all of that. And they were just being housed there. So there was this transformation that goes all the way back to the 1970s that says, hey, we've really got to change this. And so when that started happening, then in the 1960s, the deinstitutionalization of mental health services and the profound lack of community-based services or resources, police were put there in order to fill the gaps, because our culture and our society didn't have the things in place to properly provide for these individuals that they were moving out of the hospitals, these group homes and stuff like that. By the 1980s, a central mechanism of reform, specialized police training designed to improve officers' knowledge of and attitude towards mental health vulnerabilities while shaping their decision-making in favor of appropriate de-escalation techniques. So what that says is they're starting to notice, okay, maybe we really need to put more of a focus on the way the police are interacting with individuals who have mental health diagnosis, and really try to work towards an improved way of de-escalating someone, rather than just putting them in the car and taking them to a hospital or something. The focus has been cross-system collaborations and cooperative agreements between mental health and mental health drop-off facilities best equipped to perform psychiatric assessments. So that could be your hospital. So an individual gets, someone calls 911, the police show up, and then the police officers are then taking the individuals to the hospital in order to, so the individual can get good services. And then as the effects of deinstitutionalized continue to increase, police experience an increased mental health response associated with the gaps in the community. So again, the deinstitutionalization of individuals with mental health diagnosis, it was almost like a full sweep. It was just like release everybody, put them back out there in the community, which was good, but they just didn't have the skills and everything is necessary in order to really support the move of the deinstitutionalization. So what is the research saying? There was these studies done, and there was 85 studies, so a collective of 85 studies covering over 300,000 cases. And in those cases, it found that 1 in 4 individuals with mental health disorders have histories of arrest. 48 studies also indicated that about 1 in 10 individuals have police involved in their pathway to mental health care. That's a lot. You know, when we're really thinking about things, it's just a lot of interaction. The Treatment Advocacy Center of 2011 found that 1/4 of people who were shot and killed by police have a severe mental illness, which was creating a 60 times likely greaterhood to be harmed. Many factors influence whether mental health disorders will be identified by the police, skills of police, and people often do not disclose mental health issues. In the United States, having a mental illness is still really stigmatized. So a lot of individuals aren't comfortable saying, I have a psychiatric diagnosis, I have, schizophrenia, or I'm someone living with schizoaffective disorder. And then they don't have a lot of trust to be able to just say that, because the stigma here in the United States is still really high. So what kind of approaches do we have in the United States? So there have been a couple that have been created over time, and these are some of the primary ones that have been created. So we have crisis intervention teams. So we also call them CIT officers. And these are police officers who serve as first responders to mental health crisis. And this is also known as the Memphis model. We have mental health liaisons. So they are either a contracted provider or a police staff that are called out to a scene as secondary responders. So they're called afterwards. And then you have co-response teams, where you have mental health providers who directly respond to 911 calls with the support of police. So in the United States, police officers are often getting called for everything, right? They are getting called for a wide range of different things that are happening in our communities, whether it is public disturbances to more serious incidences involving threatened or actual violence, and people exhibiting a variety of mental health problems. And this doesn't have to be like just, severe mental health diagnosis. It could be dementia, it could be intoxication, intellectual disability, or serious mental illness. So the police officers in the United States are responding to not just criminal type things, but they're having to respond to a lot of these other types of things that are going on in our community. And what are they saying is the frustration. So police officers have often stated that a lot of times when they get a call and they're being dispatched to a mental health incident, what they're having to do is they'll get the individual, they'll transport them to the hospital, and they're not even guaranteed to have the individual be admitted. And so a lot of times they're saying that this is a waste of, not a waste of time, but it's not as, they're doing things that aren't always going to lead to the best support that the individual needs. It's placing a great demand on police resources. And that's not just the active police officers who are engaging with individuals in the community. This is our dispatch centers. These are, detectives, everybody involved. It's just creating a lot more of a demand on the police resources that we have. And then deficiencies in the system that severely constrain their ability to resolve situations involving people with mental disorders. So again, that kind of goes back to the previous slide where I was noting how the deinstitutionalization kind of just fell out without having a lot of good foundation to support the individuals that were being moved out of these psychiatric hospitals and care homes and stuff like that. So there was just a lot of deficiencies and not a lot of connecting. And then they were really they're just really curious if their efforts assist people in crisis. Like if this is really promoting overall meaningful public health and better outcomes. They're just not sure if what they're doing is really working. So not only do we have to look at the law enforcement frustrations and concerns, we also have to look at the public, right? Because if you go back to George Floyd and a lot of other individuals who have had interactions with police, there's a lot of concerns. And so we really want to look at both sides of the coin. So when it comes to the public view, there's systemic bias that has led to the over-incarceration of people with mental health disorders. It is not uncommon for a lot of individuals who have a mental health diagnosis to be sent to jail for something that they did while they were not doing well, particularly people of color. So that's what the POC means. So that is the people of color. And police are more likely to respond to mental health crisis with violence because they just don't have the training and the knowledge to best support the individuals. And so when they're interacting, they just see this, they see the behaviors and they want to react. Again, this is more, it's increased when the individual is a person of color. People in general, not just the police, are not good at violence prediction or detection. So an individual can be acting a certain way, but they're not quite, we can't predict whether that person is going to be violent based on a certain behavior. So current de-escalation procedures and protocols don't account for the role that mental health distress plays in these interactions. It can only add to some of their symptoms. The way that they're being engaged by the police officers is only, in their eyes, by the public, it's just making things worse. It's playing a role in the overall stress when it comes to mental health. And police make different attributes about the behavior being exhibited by people of color more likely to see them as characteristically violent than seeing them as experiencing a mental health crisis. In the United States, we have a major issue with racism, systemic racism, and it is something that we are always working towards improving, but we're not out of that hole yet. And so it's really important to acknowledge that a lot of people are still being impacted simply because the color of their skin and these beliefs that have been held by many people. So that is something else to really take into consideration when we're looking at police interaction with people who have mental health diagnosis. So Steve and I also work in a hospital setting. at a hospital inpatient setting. And one day I was in there, and while I was creating the activity board, I had a couple individuals in there who were up and early, had their breakfast, and were sitting there. And this was not even a month ago, I don't believe. And I was changing the dates, and then I turned and I saw this. And I said, oh my goodness. And I immediately turned and looked at the individuals in the room, and they just looked shocked. They were like, oh my gosh. And they even got up and left the room as soon as this popped up. And this happened in North Carolina. Edgecombe County is a county in North Carolina. So this stuff is very, very real. Individuals with mental health diagnosis are continuing to experience a lot of different types of interactions with police officers. And the individual's cousin, the individual that passed away, she said, I hate this had to happen. There's no justification to what happened, but due to his mental capacity, he couldn't help what was going on. He was not of his self. And the Sheriff Atkinson, the gentleman in the picture, reported that the incident could have been avoided. And he's calling on the state to invest in new resources. This just happened a month ago. There are so many things that are still happening. This is a very relevant topic and concern that is going on, but we're hopeful with changes.
So here in North Carolina, where both Ashley and myself are located, we've had the CIT officers, which we mentioned before, where the officers are trained in how to work with individuals that have mental illness. Since 2005, North Carolina has had CIT officers, but less than 30% of the officers in North Carolina are actually trained in CIT. Each department has such a different approach to how they're handling individuals with mental illness, much less, the decision about CIT as opposed to if they're going to use a mental health liaison team or a co-occurring response team. So counties and each individual department's trying to figure out on if they're going to do anything for once, and if secondly, what they're going to do, if they're going to do anything to address it at all. And a lot of it depends, unfortunately, on budgets and the leadership, how the leadership's point of view is. We live in an area that is, North Carolina, if you're not familiar with it, is a southern part of the United States, and has some very rural sections to it, as well as some very large cities. And so the work that Ashley and myself have been doing with the police in North Carolina, because since 2020, after Floyd, numerous North Carolina cities have started to announce plans to create the co-response teams, where they have therapists on the team as well as the officers that are responding directly to the 911 call. So unlike the CIT officers, where you may or may not get a CIT officer when you call 911, it depends if an officer is available. With co-response teams, they're responding to the 911 calls directly. And that's a little bit different than when you have the other agency where they respond secondly. Either the officers call and have the agency come out and respond to it, or the agency is kind of called out at a later time. So the city that we're addressing has 771,000, and they created a co-response team after their previous team that they had created several years ago was heavily criticized by the media and by the public for very slow responses, for not having a very good reputation in the community and not being trusted. So the team contracted with where Ashley and myself work at UNC Institute for Best Practice, because we have a reputation for working with individuals, community mental health treatment for individuals with psychosis. And so that's where we came in, as they found it as being the closest relevance for what they were looking for. So what we have done, I will say also, I should state that in addition to this training that we are also providing to this co-response team, is we are also supervising clinical supervisors for some of the therapists that are co-members of the team. So we provided a 3-part mix between interactive and didactic training with the response team, which is the entire response team for the city. There's the one response team that responds to, regardless of what district in the city is the 911 calls are for, they respond across the city to the calls. And that includes the police officers, the therapists, and their supervisors attended our training. The therapists all have master's degree, but have a mix of experience, anywhere from parole officers to mobile crisis and to child protective services have been their past work histories before they took these positions. All of them had under 5 years of experience. So none of them were even though they had variety of experience, none of them were very experienced therapists. The officers have a variety of experience within their profession. Several were CIT officers. Several have hosted hostage negotiations training, and several are school resource officers, where, if you're not familiar, it's common in the United States to have police officers in the school, and that's called the school resource officers. The mean experience for the officers was 9 years of being on the force. The 3 trainings we provided, the first one was just the basics of understanding psychosis. It was a lot of psychoeducation about individuals with severe mental illness, what it looks like, and what treatments are available to those individuals, and the resources, and what the difference between hallucinations and delusions, and what that looks like. And then we did the theory behind CBTP, the theory behind cognitive behavior therapy, using the Turkington Kingdom model. And then we also did CBTP interventions, using a combination and integrated approach between Turkington Kingdom CBTP theory and from the late Aaron Beck's recovery-oriented cognitive therapy, the CTR approach. Activities included addressing their automatic thoughts, hearing voices, simulations, helping individuals by not confronting their delusions, refocusing techniques, building trust with the individual, normalizing psychotic symptoms, avoiding any labels, and identifying the individual's goals, what was important to those individuals.
And Steve, we had a question pop up. I was going to answer it.
Go ahead, I saw it.
Yeah, so where are the peer supports? So earlier when we had noted, the 3 different types of things that the United States have, so the CIT, the mental health liaison, and the co-response teams, unfortunately, there are no peer supports on them at this time that I'm aware of. But it wouldn't hurt in the future. But just right now, what we're talking about is CBTP within these already developed systems. Yeah,
we're not aware of any in North Carolina that have peers on it. It's enough a challenge in North Carolina to, it's a constant battle, both financially and through leadership of each city or county, to have therapists on the teams, much less looking at other options at this time. So why use CBTP? So we've kind of explained how we've gotten here and what's going on. So why CBT is the gold standard for treatments, along with medications for individuals with severe and persistent mental illness. Here in the United States, SAMHSA, Substance Use Mental Health is announced finally, which I know that there might be people on this call that were heavily involved getting that passed. Finally got SAMHSA to agree and to announce that it was a frontline approach to treating individuals with psychosis. So it was the timing that this was taking place. CBTP can also reduce the stigma within the police departments through education and also the effectiveness of it, being able to see results. And CBTP is fairly easy to teach and aligns well with the recovery principles that are important to us. Go ahead, Ashley. So for de-escalation, it allows for the clinical response to someone in emotional distress if we're using CBTP. Typically, there's that authoritarian response that we have seen with the police in the United States that can often trigger these core beliefs of the people that they're responding to. And people with psychosis are not commonly violent. We know that we're preaching to an audience here that very clearly understands that, but in any talk about the police and mental illness in the United States, it needs to come up very clearly that there is no association, even with individuals that are experiencing a mental health crisis, that they're commonly not violent. So who would benefit from using CBTP interventions with the police officers? In the work that we've been doing, we feel that it's appropriate for the CIT officers and the CIT officers that are members of a co-response team to learn these techniques. We've also believed that the mental health liaisons that are responding, the therapists and peers that are responding as mental health liaisons, can learn CBTP and utilize it, and also the therapists on co-response teams in our work have been using it, and we'll get to that in a minute. So we have to make some modifications to CBTP with the work that we're doing, we've discovered. We have to address that there's going to be some non-therapists using these techniques because police officers, there are a couple of police officers across the country that are also therapists, but that's not very common. Most of the officers responding are, not therapists. They're the individuals that we're working with. It is in community setting. A lot of CBTP work has been done in, inpatient settings and office-based practices. I mean, there are, with my work with ACT and Ashley's work with ACT, we see a lot of that being used with the Survey Community Treatment, which is a community setting. But typically, majority of CBTP has been office-based. There's little to no information on the person's history when the team is responding. We don't have the typical information from the medical records and from previous referral sources, providers that worked with this individual when the officers and the team is showing up. There's the recognition of police distrust that we have to acknowledge when the police are pulling up, when the response team is pulling up. It's usually very clear that they're members of the police. That there's no scheduled sessions. And there's uncertainty if or when the person will be seen again as a challenge when we're talking about co-response teams. And this, the integration of different approaches within the cognitive behavioral therapy approaches for individuals with psychosis. So what we've learned and what we're utilizing are two different steps to responding to the police with individuals with severe mental illness. One approach that the officers made it very clear to us and the therapists on the co-response teams is they divide in their minds, they divide their calls and their work into these two categories. One is the responding to 911 calls, where they get that 911 call, the only information they have is what that 911 dispatcher was told and what is being relayed to them from what's going on in the scene, and they're showing up. So very, very little information in those situations. The second part is when they're following up with the individual. So they've met the individual, they have more information that is usually the therapist with the work that we're doing. So those are the two types of interaction. So to give a little bit of an example here, this is kind of a combination of with the work that we've been doing with police. We kind of threw together this template for the rest of our conversation this morning. So Johnny is in the middle of Main Street. He is talking to himself and pacing rapidly. He's hearing voices, and he has received mental health services in the past, but it's been quite a while since he's met with his assertive community treatment team. And a shopkeeper has called 911 out of concerns. He is not suicidal. Aaron is the therapist on the Coresponse team, and Anthony is the officer. They arrive on the scene. A small group of people have gathered on the corner, some with cell phones out, which if you're not in the United States, that is not an uncommon case when police officers arrive for citizens that are bystanding to pull out their phones to record what's going to happen, because that is how a lot of the situations that have occurred in the United States have become public, is because of people's cell phones. So the goal of the team in this situation is to de-escalate the situation and to avoid Johnny going to jail or to the hospital if possible. Aaron is mindful to approach Johnny in a non-confrontational way. Anthony could approach the group of the bystanders and to kind of explain that help has arrived and encourages them to consider his privacy, which is frequently an issue. Anthony also approaches the shopkeeper to provide any education. So with this approach, we're responding to 911, we kind of call the EEG approach. So this is when responding to 911 calls. When the co-response team is not familiar with what's going on with this individual, they have the 911 call, they may or may not know the person, they show up on the scene. First step is the engagement. They're taking the time to engage with this person. This might involve several attempts to find a relatable topic. The next step is to empathize with the person. They're connecting with the individual as a person, which is the key. Not as a suspect, not as somebody that they might have to bring to jail. They're connecting with them as a person that's in distress. They validate the person's emotions and experiences. They're not rushing to make certain the person feels heard. They're taking their time. They could be using the step approach where you're summarizing, testing, empathizing, and then again proceeding. Because people respond better when they feel respected, when they're treated fairly, and that the interaction is transparent. There's nothing being hidden in it. So the grounding technique is the third piece of the EEG approach. The officers and the therapists might not be sure if they're going to see this person again. So what can be done in this short amount of time to make the most impact? It might be using the look point name from the recovery oriented cognitive therapy approach. It might be using the chain analysis. It could be refocusing techniques. It could be having that person read different signs out loud that they're near. It could be helping the person schedule the voices. It could be listing positives that the person can come up with to counter the voices that they're experiencing. So that's what we're doing with the EEG technique. It might be a long time that the officer or the therapist are spending in the engagement and empathizing with the individual, but these are not very technical pieces that we're working with at this time. We're keeping it simple to help this individual with the stress that they're experiencing at that time. And now we're going to move to the follow-up approach that we have been using with the officers and to the therapist. The follow-up approach is a little bit different than what most therapists experience in their practice. Johnny in this sample would be added to Aaron's caseload. Locating the person for follow-up sessions can be a big challenge, and it's kind of an ethical issue sometimes for the therapist. How much of the police resources do they use to follow up with this person? You know, because police have a lot of different ways that they could do it. Is it, you know, if another officer sees that individual when driving past them, are they going to notify the therapist, all the way to they could even track the person's cell phone, has been brought up. So those are ethical issues that always need to be addressed. Improving the relationship between the individual and the police. The therapists that we've been working with, the co-response team, they wear these all black shirts and pants, but it is very clear when they show up on the scene that they are with the police department. That's an issue that they're having to face and to address. The hope of increasing the use of available treatment services in the community. Building natural supports for education and problem solving to help use those family members and those loved ones of this individual. And it often looks a lot more like community mental health sessions when we're talking about the follow-up. And so what can we do during that? We call it the SWIFT approach. It's time for therapy. This is therapy, so it's usually done by the therapist on the co-response teams. Again, they're engaging that person. It might require numerous brief check-ins with this person. It might be check in with this person a couple times during the week. They might be these sessions that just last about 10 to 15 minutes at first. They're helping identify the stressors, what supports this person has, and what resources they have available to them. They're providing education. How do people respond to stress with anxiety? How does anxiety affect their psychosis? What triggers do they have? What are their automatic thoughts? They can go in depth and identify the core belief if they get to that point with this individual. They can address where that core belief came from. That first episode, how does that relate to the core belief? They can explore the core beliefs are reinforced by the system and talk about how the police can often trigger these core beliefs that are the person's having. They can discuss alternative explanations to the thoughts that that person's having. And again, we're making sure that the co-response team is not confronting or arguing with the individuals around their delusions or hallucinations. That's something that we're heavily trying to avoid at this time. So the feedback that we're getting from the co-response team is that the positive feedback is that using CBTP is with individuals that are experiencing psychosis. It's very simple. It gives the staff direction what to do. It's effective use of the resource. They spend less time in the emergency rooms, which I cannot stress how important that is, what we're hearing from our officers. They feel like so much time that they're just stuck in the emergency rooms, just waiting and waiting. And the follow-ups allow them to see the positive change in the person's life. They're not just seeing that one snapshot when this person's not doing well. They're seeing the person at other periods when they might be interacting with their family and seeing their hobbies and their jobs and other interests that these people have. It helps see them as individuals. The challenges that we're coming across is helping the officers specifically understand the relevance of CBTP, why the individuals with psychosis need a different treatment than what they've been doing in the past. We're finding that the officers specifically often mistake psychosis for the use of substances. We're aware that there's frequently co-occurring disorders that people are having, but a lot of times the officers are assuming substance use as opposed to psychosis when they show up to see. And then some officers have been very hesitant to change, even if they're CIT officers, even if they're officers that have had numerous other training experience. So what we've learned is that we need two different approaches when using CBTP for the police department mental health teams. That calling 911 response and then a follow-up with the therapy. Most officers are willing to learn the new approaches if they are not put on the defensive. If we respect the officers and don't put them on the defense, which happens frequently, and when officers and mental health are mentioned in the same sentence, that if we listen to the officers and their concerns and frustrations, especially around sitting in the emergency rooms, we find that they're much more likely to learn techniques that can help these individuals when they're struggling. Limitations, of course, is the funding, the leadership, getting through those strict gatekeepers that the leaderships have. It's often really hard to get in to work with the police departments. And how divisive this topic is within the US, and that each city takes a different approach. With the different cities that we're talking in North Carolina about doing something similar with, we have to jump through various different hoops, and it's always different hoops depending on the city and what the needs are.
Yeah, it's only about 3 minutes. I hope we get to questions. Thanks.
Sure. Thank you, Ron. So where do we go from here? We need to figure out who to get on board in each location. And I mean, that can vary anywhere from mayors to city councils to county commissioners, because police departments in the United States are set up very differently in each area. And how would this be funded, of course, is the biggest question. For those in the United States, they know that that's constantly in the news, is that issue about how to fund mental health in the police work, how to fund CIT, how to fund mental health liaisons, how to fund co-response teams, and then how to expand the use of CBTP more among police departments that are commonly responding to individuals that have psychosis. And I think we have our references slides, which will make sure if anybody needs that.